How do you respond to the arguments that rolling back expansion would hurt people's coverage and therefore their access to mental health services?
Well, in North Carolina, as Speaker, we didn't expand Medicaid under Obamacare. And the reason that we didn't is I wasn't quite sure what Congress was going to offer the states at some point in the future. Because, again, when measures get passed that are purely on partisan lines, then they're always subject to some kind of change going forward. So I told my team that if we wanted to look at populations we needed to expand Medicaid, then let's do it under the current reimbursement rules so that we don't suddenly create a system that could be at financial risk should the rules change. And they almost changed last year. But what we also did is start working on expansion of accountable care organizations. Now we've got some of the best examples of capitated models that are working, that the healthcare providers like. We went through a lot of challenges to get them going, to where we're driving down the cost of care and freeing up those resources to expand services. So at some point we have to recognize there's a lot of inefficiencies in the Medicaid system that should be driven out so that we're getting better quality care, more access to the population. And I think that right now it's just become an either or. I think there's something in the middle that would probably address the fundamental concerns of all but people on either side of the aisle that just want a political win. That there's a way to do it to where you can expand care, but you do it and bend the curve. When I came in as Speaker, I had a $750 million shortfall in the year that had to actually be paid for with next year's dollars. And we could not afford to sustain that because it was putting at risk. When you have a Medicaid shortfall, you've been in the legislature, you know how this works. You usually cut provider rates. And then that actually causes a number of issues that are, at the end of the day, harm the patient. So you got to go in with your eyes wide open if you're going to expand it and make sure it's sustainable.
Of course, we also have the private coverage, and most Americans are covered by employer-sponsored plans. And we had the mental health parity law, which was passed, I think, in 2008 or 2009, but then the ACA strengthened. But there's been quite a lot of reporting on how implementation of that law has been pretty slow among insurers. Of course, the law requires them to cover mental health services sort of on par with other health services. And I believe the Labor Secretary has asked Congress on numerous occasions for more authority to kind of crack down on these insurers to implement the law and put its provisions in place. Are you aware of that? Do you have any thoughts about how we could kind of speed up this provision of mental health services among private plans?
Well, part of it is just the availability of clinicians. We were talking about psychologists and psychiatrists. I'm thinking of East Hawaii, Hilo Town. Our perennial challenge with the agency that I ran was we just couldn't get a psychiatric nurse who could last on the Big Island. And it was an incredible challenge. So we, in the state of Hawaii, we have the Prepaid Healthcare Act, which is actually something we should do nationally. You'll hate it, Tom, but anyone who works 20 hours gets health care. And it's clean, the business community likes it, and everything is more expensive in Hawaii except for health care. Even on the private side, even on the Blue Cross Blue Shield side, it is the cleanest way to do it. It is a mandate. It's you work 20 hours, you get health care. And we have very aggressive parity laws, a Democratic legislature and a strong advocacy community. But the challenge in terms of parity, in my view, is not purely at the reimbursement side and the way the insurance companies operate, but it's just the availability of clinicians, which is why I'm evangelical about telehealth. I'll say it again, but also we need to do more training and to be adults about scope of practice. I came in, as I just mentioned, a doctor's son, kind of a hard-nosed guy about doctors versus nurses and psychiatrists versus psychologists. And over time, I just realized that is a theoretical exercise when nobody is willing to care for people in rural communities. And so it's about getting providers out there. Sure, you'd always rather have a more well-trained individual wherever you can, but you just have to deploy people who can provide care wherever they can.
Senator Tillis, do you have any thoughts on mental health parity, or is that something you've...
I agree with him. I hate the one option, but everything else he said, I agree. Yeah. Now, I think what it comes down, this is really where I think reasonable people need to sit down and say, instead of this either or, I think we all ultimately want everyone to have broad access to health care. But we have to get to the sustainability question, and it has to be the whole of government. It can't just be a federal solution. As a state legislator, I think we can play a role. A lot of our urban leaders would play a different role than our rural leaders, but if we really want to solve this and make it less of a political lightning rod on how you solve it and sustain it, we have to have people sit down and even recognize what may work for Hawaii with a very different industrial and business mix may not work in North Carolina. So we start looking at how we come up with enablers from the federal government that let the states execute these with the ultimate goal of everybody having access to whatever healthcare service they need. If they can pay for it through a private employer, great. If they can't, then the safety net exists to help the others.